Hello, everybody. Welcome to our online discussion on the question global health, what's next? Thanks for turning up. We're looking forward to a lively event dedicated to an important question. I should mention that this is both an online element of this year's Circle U Summer School in Global Health and an open conversation held by Circle U. My name is Christoph Grabmann, and I'm a professor at the University of Oslo, Medical Faculty, Institute of Health and Society. My specialty is, in fact, the history of global health. And that brings me to what we want to talk about today. In history, things have a beginning and an end. Even though we often do not think very much about the latter, the end, we focus on the beginning. We also seem to be in agreement as to when global health came about. Most of my historian colleagues would place this into the 1980s. The Cold War ended with the Soviet Union's collapse. It was followed by decades of unipolar Western dominance in politics and economy. The WHO was in a crisis and got mediated by a plethora of NGOs, which became a defining feature of global health. Low-income countries in the 1980s went through sometimes catastrophic economic crises, and global health was one of the answers to that. Yet, over the last year, it has become clear that global health, a child of Western political dominance, governance, and finance, is in a deep crisis. It might, in fact, be a thing of the past, and that is fascinating for a historian. The United States of America, to name the most obvious evidence, have started to withdraw from central funding mechanisms for development aid and global health interventions. Most of us will remember the dramatic announcement of President Trump in January when he put all foreign aid programs on hold. US aid, I think, is no more, for instance. How sponsor-driven global health public-private partnerships, such as the Global Fund or the Gavi, are to operate in the future is unclear. For instance, national control programs for diseases, which global health had so much centered on, are facing an insecure future. The United States' withdrawal from funding mechanisms also has a geopolitical dimension that only begins with the Chinese challenge to US hegemony. We saw sheet lightning of that in 2020, actually, with Trump's first attempt to leave the WHO, which was quickly exploited by the Chinese gaining influence in Geneva. In the larger picture, there's a geopolitical lesson here. We have left a unipolar world, but how a multipolar world will be looking like is very unclear. This is often framed as a discussion of the role of BRICS countries or of the European Union in the future of global health. Again, the outcome of such discussions, not to speak of what the future will bring, is very unclear. Things are not getting easier when we realize that global health, beyond finance and geopolitics, is also challenged epistemologically. What do I mean by this? I mean, when its knowledge regimes, evidence-based as they were, are challenged by fake news every day. Well, we are here together in no possession of divine insight, and we cannot make a prognosis. But we can try to comprehend where we are. To help our discussions, we have invited 3 experts to give us their viewpoints in short contributions. After that, we should share our views and questions. In this meeting, we will record the statements and introductions, and after that, the discussion will not be recorded. Let me introduce our speakers with a few words. Our first speaker is Peter Mangesho. Peter, there he is, holds a PhD from the University of Cape Town, and he works for the National Institutes of Medical Research in Tanzania. He has worked on many things, but I would like to mention HIV, antimicrobial resistance, malaria, and he actually works on the history of drug industries in East Africa. Our second speaker will be Dr. Antoine de Beigny-Puvalet. Antoine has a PhD in political science from the University of Oslo, and he's employed at the University of Oslo's Center for Global Sustainability. Antoine has worked extensively on global health partnerships and NGOs such as Gavi, Gates, or the famous funding mechanisms for COVID vaccines, COVAX. Our third speaker is Jason Grant-Rawls, one of the PhD students with whom we had the great, albeit somewhat hot, pleasure to work in the summer school last summer. He is a trained criminologist, and it strikes me that in the current state of world politics, that might actually be a very useful qualification. Jason currently takes a PhD at the Institute for Psychiatry, Psychology and Neuroscience at King's College London. He has promised to supply us with a short statement from his field, mental health. So let's first listen to our three speakers, scribble down our questions for discussion, and then have a discussion after their statements. We have a total time window of 2 hours, but probably we might just finish a little earlier. We'll see how it goes. I'm looking forward to interesting statements and a lively discussion. And I think our first speaker will be Peter. I give the word to you, and you can share your presentation. You have to unmute, otherwise, yeah.
Hello,
okay.
Hi, thank you, Christoph, for that introduction and for organizing the talk. If you'll excuse me, I will mute and probably stop the video because of internet connection issues. Can you hear me? Okay, so I'm going to give a short overview of the US withdrawal of funding and impact on health services in Tanzania, with the focus on USAID and PEPFAR funding bodies. I'm a social anthropologist working with the National Institute of Medical Research in Tanzania. I cannot seem to control my... Okay. So my outline will highlight the key health support areas by PEPFAR and USAID, their contributions overview, and models that have been given out by different authors and scholastic articles about the impact of the cessation without replacement of the funding. I'll also talk about the impact highlights, how the government of Tanzania responded, and the way forward. So there are key areas that USAID and PEPFAR are funding in Tanzania, and for the part of USAID, their focus has been on maternal and child health, malaria, family planning, nutritional programs, TB, as well as health system strengthening. And I'll talk about later on how this has been done. While PEPFAR, the presidential funding body started by Bill Clinton, I think, if I'm not, no, by George Bush, focused mainly on HIV and AIDS services, including HIV/AIDS testing, counseling, and antiviral therapy, but also in the areas of orphans and vulnerable children, but as well as laboratory and health system strengthening around HIV and AIDS services. Over the years, USAID and PEPFAR contribution to Tanzanian health services has been around 700 million US dollars annually, but this is the pre-withdrawal period. Again, this amount amounts to 20 to 25% of Tanzania health sector budget in years when foreign aid was around 30 to 40% of total health spending. You should be aware that I want to make it clear that the current funding has not been reduced only because of the USAID funding cuts, but gradually the funding has been reduced, been dwindling since the 2017 years, and especially after the impact after the COVID epidemic. But this has to be, we have to acknowledge that over the years, PEPFAR have been useful in avoiding deaths. Saving lives. Almost 25 million have been saved by PEPFAR, and countless of new HIV infections have been averted. Now, what do we know about the cessation? I would like us to hear a little bit about what happens when there's no funding replacement. That's according to recent studies, shows that projecting from 2025 to 2030, there will be increased HIV-related death from around 4 million to 6.6 million across 15 countries. And if there's no funding replacement, tuberculosis death may occur up to around 768,000 in 79 countries. Additionally, almost 55 million unplanned pregnancies, 16 unsafe abortions across 51 countries, but also almost 3 million to 5 million child deaths from causes other than HIV and tuberculosis across 24 countries. This, if it happens, if there's no funding replacement, this will threaten to derail the joint UN programs on HIV/AIDS goal of ending the epidemic by 2030. What has been the impact of funding in Tanzania health services? The recent cessation generally disrupted services in a way that certain communities could not cope well. Community health outreach efforts were slowed down. The coordinations were shaken up, and the health systems were disrupted overnight because people were told by letters. I know in our office where I work, we conduct health research in HIV and AIDS. Staff that were providing service were asked to stop working, and it left health workers and communities without the tools and support that they had to rely on. There were, USAID supports and PEPFAR supports programs through providing funding to health programs. These are independent health programs integrated in the healthcare system. Around 20 to 30 active health programs in Tanzania by USAID, and PEPFAR has been supporting up to 20 programs annually, both with linkages to public and government health systems. About 50,000 health workers affected by USAID's shutdown alone, according to IMF. 20,000 Tanzanians working directly and indirectly in the health sector affected by the shutdown, while 30,000 government health workers who received supplementary income were affected. This has impacted supervision and quality control efforts. And this has meant that programs have been shaken. For instance, if you quantify if there was no replacement, around 500,000 TB screen tests could not go unattended, and additionally 1.3 million will lose access to HIV testing. Local health systems heavily reliant on donor funding will struggle to maintain services, increasing the vulnerability to uncertainty and health due to health budget cuts. What has been the government response? The government issued statements, including commitment to supply ARVs to the 1.7 million affected people. The recent budget, the government has allocated before the budget of 2025-26, almost 154 million was provided by the government, 15 million US dollars, but also 60 million US dollars was allocated for the fund for replacement for the year 25-26, and it has committed to raise new funding from new sources. For instance, it has promised to push for compulsory universal health care insurance, reviving AIDS Trust Fund, increased tax on alcohol and sugary drinks, but also duty on electronic communication gadgets, and levy on increase on petrochemicals like fuels and others. Then we had the challenge of the health system worker loss. So far, the government has been able to somehow, I don't have the numbers, but to absorb some of the skilled health workers that were trained by PEPFAR and USAID into the government payroll system. it has created a care and treatment center database whereby the roles that were performed by USAID-funded data clerks now has been replaced by healthcare workers, and broadened the role of the medical department in distribution of essential healthcare commodities. Sorry. But on top of all that, it has commissioned the Tanzanian Commission. It has commissioned the Tanzania Commission for AIDS to conduct a detailed assessment on the funding freeze on all HIV programs. So to conclude, what next? So we know that the cuts did immediate cause severe public health crisis. The government responded with political and financial commitment in maintaining health life-saving services. It used the crisis to fast-track crucial structural reforms to increase financial reliance. But we are waiting to know for sure what has happened. It will be very important to detail an assessment of funding cut, to have an assessment of the cuts in all health services, services that were affected. But what next? It's my opinion now. I know we're going to discuss other funding bodies, but I would like us to focus on internal funding possibilities, and which reminds me of the 2001, I think 19 years ago, Abuja Declaration, whereby governments in Africa, almost all of them committed to pledge 15% of the GDP of their budgets to healthcare services. But until 2010, until now, only 3 countries, that is Gambia, Rwanda, and Malawi, have reached the 15%. And I'm certain that if this amount is raised by government internally, we will be able to avert future crises relating to donor funding. But also, even that, we will also need to have a continuous engagement with the partners, seeking other multilateral partners such as WHO and Global Fund, to assess the situation and discuss modalities for securing alternative funding, so that we could reinvest that funding to cover immediate and shortfalls when needed. Thank you for listening.
Thank you, Peter, for very, very interesting insight. And we're moving immediately on to Antoine from East Africa to Norway and have your perspective.
Thank you, Christoph, and hello everyone. I'm just sharing my screen, and I think now it's on. Yes, perfect. And I'll just move my camera so that I can watch my screen and talk to you at the same time. All right. Hi everyone. So my name is Antoine de Benji. I'm a political scientist, as Christoph introduced me. I work on the global health governance, basically. So the systems that are in place at the global level to deal with global health, and my interest lies mainly in how donors act and what do they do with global health. And so I'm very happy to be here today. I wanted to talk about global health partnership specifically, and hopefully you've learned about them in your summer school earlier, but in case you just need a refresher, global health partnerships are multi-stakeholder organizations. They were created in the early 2000s, the first one being Gavi, the Vaccine Alliance, and they differ fundamentally from the World Health Organization in that they bring a wide range of stakeholders together around the same decision-making table. So those who take decisions are not only member states, but you also have philanthropic foundations, notably the Gates Foundation, NGOs, and private commercial companies. Another thing that's quite specific about global health partnerships is that they are narrowly focused. So they have like these kind of vertical interventions, laser focus. So Gavi would focus on vaccines, or it might be another community like Unitaid, which focuses on drugs. It might be focused on diseases like HIV/AIDS, tuberculosis, and malaria in the case of the Global Fund. And as you can see on my slide, we've seen a proliferation of this model throughout the past 2 decades. And this model has been quite successful in saving lives, and that's what they count. That's how they measure their success. Their interventions are based on measurable outcomes, like the number of vaccine you distribute, and then you make prognosis of how many lives you save. And so, as the slide shows, all of them highlight saving millions of lives, and to some extent, they've really managed to mobilize donor funding and really put some issues that were neglected before on the agenda. And in that, it's really remarkable what they achieved. Just a quick overview of the budget. You see here Gavi, the Global Fund, and the World Health Organization. And as of 2023, both the Global Fund and Gavi had a larger budget than the World Health Organization. And I don't think many people are aware of it, but it's, it's really, these are big organizations now. And when you think of global health, you also often think of the WHO, but it's, it's much more than that. Just a quick word on the key challenges of these organizations. We've, had 25 years of work of these organizations. I highlighted what the great things they've done, but some of the criticism that emerged are that they are based on a charity-based model, where, you really have a few donors that set priorities for very important parts of the national health system in recipient countries. And these organizations are very much structured around the top-down kind of, a board decides and then the priorities trickle down to the ground. And just as a reminder, the top 10 donors that you see on the slide here, which are all Western nations and the Gates Foundation, amount to 82 to 88% of the funding of the organizations that I showed you earlier in the slide before. So without these donors, there is no global health as we know it, structured around global health partnerships. That's a key takeaway. Another set of criticism that have been raised against these partnerships is that their vertical focus on one specific commodity or specific disease has fragmented the recipient country's health system. So you would have some nurses that do one thing and some other nurses that do another thing, and then you have different systems that don't talk together, and very difficulties for the national health systems to control what's going on and plan accordingly. Another set of criticism is that these interventions have not been have had a substitutional effect. So that means that the aid that came basically replaced whatever government funding was there, instead of adding to what was there before. And so, of course, some of these mechanisms have co-financing requirements, and you still have some national budget. But basically, when you see, and we see it happening right now, when the donors pull out, it's really hard for the countries to step up and fill the gaps. And of course, and that's kind of a broader point, but the focus on very specific commodities or specific disease have also prevented some larger conversations on the political determinants of health, for instance, or factors that shape health outside of the quick fixes that the vaccine might be, and they might be necessary, but we haven't really discussed nearly enough the root causes of ill health, and these partnerships really don't tackle that at all. That's not their job, but they've become so important that they kind of captured the debate by setting the agenda around very narrow goals. And then came COVID, and the COVID crisis basically was dealt with by putting all of these global health partnerships that have been, or many of them that were created the past 25 years, together into a kind of, we called it with colleagues, a super public-private partnership. So a kind of loose institutional framework to coordinate work on the COVID crisis. And the promise was that countries would have equitable access to vaccines, medical treatments, and diagnostics. Of course, we know now that that didn't happen, not in terms of equitable access. Like in 2021, it was massive gaps in the vaccination coverage between African countries and Western countries, for instance, where we in Europe were boosting with a third dose, and only 8% of people in Africa were vaccinated. And of course, it created some reactions against the system. A lot, and I just put in some quotes here. COVAX, which was the setup to distribute vaccines, the president of Botswana called it a scam. A very high-profile NGO in Africa called it a betrayal of trust. And I think that's really left a profound mark in the global health landscape kind of creating a distrust that, okay, we cannot trust that the donors, we cannot trust the institutions that are created there to help us. And so following the COVID pandemic, you had a lot of efforts to try to rethink how can we work together with both with the institutions that we have and maybe create new ones. And so one of the key initiatives that was launched was called the Future of Global Health Initiative, initiated by the Wellcome Trust, Norway and Kenya, that resulted in the Lusaka Agenda. And basically the key takeaway of the Lusaka Agenda is that we need to reform the global health partnerships so that they are better aligned with national health systems, and they need to do something about the fragmentation and so better work together. And a direct influence of this Lusaka Agenda has been to create the Gavi Leap, which is now a program of work that Gavi really has taken ownership over to work better with other partnerships. So exciting things going on here. But next to this incremental side of reform, there were more radical voices saying we need to sunset this organization. So we need to shut them down. We need a transition plan for the next 20 years and then think of a future without them where countries really are in control of what's going on. Okay, so what I've done now was to show you what was happening in global health the past 25 years, show you, discuss what happened in COVID, the immediate reaction to COVID and the failure of the global COVID response. Now then, in 2024 came the massive budget cuts that were prolonged in 2025. And as you can see on this graph, the cut is massive this year with minus 21% compared to 2024, which was also a cut from 2023. So basically we came from the COVID years with a lot of money to a dramatic cut and 10 billion less out of the about 45 billions that were available in global health pre-pandemic. So we are at a historic low now for the past 15 years. And these cuts, of course, have been most predominantly made by the USA under Trump, as we discussed. But I also wanted to flag that the USA is not the only country cutting. The UK and France have respectively minus 39 and minus 33% of their global health funding. So it's really a bigger trend. And if you look at my top 10 donors that I highlighted earlier, these are really, it makes a massive impact on these organizations. Okay, and then finally, so you have these tensions with donors cutting, efforts to reform, and here again is another reaction from African countries in reactions to the cuts, which is called the Accra Reset that was launched recently. Basically very much aligned with what Peter mentioned earlier with the Abuja Declaration. So we need to mobilize, it's a call for national health sovereignty, basically. So saying that the Ministry of Health should be in charge of the health of the populations, they should be in charge of the funding, they set the priorities, and be much more in control. And just flag here, as interestingly, as part of the partners among all the African partners that make up the initiative, you have the Rockefeller Foundation, an American-based philanthropic foundation. Okay, and that's my segue to the next, to the future, what comes next based on this. So, the first question I'm wondering is the future philanthropic? And we know that, and Christoph won't contradict me, that philanthropic foundations have historically played in global health a major role in setting the field, and most notably with the Rockefeller Foundation that basically created the WHO and had a massive influence afterwards. I mentioned the Gates Foundation, and still does have an influence, as I just showed. The Gates Foundation was absolutely instrumental in the rise of this global health partnership phase in the 2000s and the massive rise in funding that we've seen the past 25 years. And I also mentioned the Wellcome Trust, which also is increasingly involved in policy and advocacy. And so with all the traditional donors cutting, is philanthropic funding the solution moving ahead? Well, there are some signals that it might partly be the case. That's, for instance, the point about the Gates Foundation being shut down in 20 years from now. And so there will be a massive influx of Gates funding moving forward, $200 billion at least, maybe more. And we also see the launch of new kind of organizations or new initiatives. Here is one, for instance, 300 million, it's not nothing, between 3 philanthropic foundations. So here the states are completely absent. And so are we moving towards new forms of global health? Maybe. What we know is that the field has been constantly evolving, and just 25 years ago, this kind of partnerships that I mentioned, just the model did not exist, right? So maybe we're moving towards new models as well. One last thing I wanted to mention is that the burden of disease has changed dramatically from what it was 25 years ago. So before, basically, we knew that vaccines, vaccinating children, fighting the HIV, AIDS, TB, and malaria epidemics were absolutely key to make an impact. Now, the global burden of disease says that 74% of the deaths worldwide come from non-communicable diseases. And that is an epidemic that's impacting the entire world. It's not only in poor countries, it's also, in very much in the north as well. And so there is something that is an area where we need much more focus to deal with the massive increase of the issue, and that's an area where we need cross-border cooperation. Countries cannot solve it on their own. They need to have some kind of regulations to deal with these things. And so I think what's interesting with this new issue, or rising issue, let's to put it that way, is that while for vaccine and the epidemics with HIV and TB and malaria, you needed to partner with the industry to scale up innovation and to scale up, fix some market failures, basically. Here with non-communicable diseases, the industry is often part of the problem. They are selling harmful products like tobacco or too much salt in their in the food that you eat. And so it's not only about partnering to fix a market failure, it's also about regulating much more and setting standards and taxing these products. And so the partnerships you need to deal with non-communicable diseases might look very different from the one you needed to increase access to vaccines. So here is also an invitation to think maybe new and not use the organizations we have necessarily, or keep using them for the purpose they are meant to have, but also think about new organizations that are tailored to the need we have. And that was the topic of a Lancet viewpoint that I published with colleagues Sophie Harman, Simon Rushton, and Catherine Storing last January. You have the link here. A couple of other publications on global health partnerships that I wrote if you're interested to read more about what these creatures are. And otherwise, I thank you for your attention and look forward to questions.